This meeting is being recorded.
Good morning, everyone. I'm sorry. Good evening, everyone. Am I audible to all of you?
Yes.
Great. So we will start our presentation. And for the record, I'm Dr. NITIN CHAWLA. And we are going to go ahead with part 1, Ecg Made Easy. Our objective in this lecture is primarily to give you a heads up on how to assess a normal ECG, how to go ahead with calculating relevant interval, and brief overview of what to see in 10 steps how to read a pediatric ECG. Those who are participant of ECG online course, they already have received part 2. If they haven't gone through that webinar, they should go through that, and this will be a good add-on to that understanding. So whenever we have a ECG in our hand, we go through this paper, which is the ECG paper. It is a very relevant document to assess any child who is coming to you in any kind of emergency. And when you hold an ECG paper, there are two most important aspects. First is you should check for the speed at which the ECG has been taken. Though if you see in the picture, the speed of 25 mm per second with chest or limb lead with the voltage on the y-axis is 10 millimeter per 1 millivolt. So when we look at this ECG paper, there are squares which are subdivided into smaller squares. So each second is covered in 2.5 centimeter, and approximately the two squares are part of it. So at a standard paper speed of 25 mm per second, there are around 250 small squares, which is equal to 50 large squares, which is equal to 10 seconds. And before we calculate a beat per minute, we should understand that each rhythm strip should be recorded for 1 minute, and thus in 1 minute there will be 1500 small squares and 300 large squares. Why this is important? Because we are going to use this understanding to calculate the heart rate. When we check with a large square, the formula is 300 divided by large square between two RR intervals. The RR interval are the positive deflection of the QRS complex above the isoelectric line. And in the picture, it is depicted how we calculate. So in first, there is 300 beats per minute. Then there are around 150 beats per minute because there are 2 large squares, then 3 large squares, then 4 large squares, then 5 large squares. So for understanding, if we go by the extreme left, 150 beats per minute is a newborn, then an infant, then an adolescent, then an adult. Second methodology for calculating rate is smaller squares. So 1500 divided by small square will give you again the same the rate at which the heart is beating in this ECG. Last and the quickest methodology of calculating rate is in the rhythm strip. Sometimes when we do not have 12 lead ECG and we take only one ECG strip, that is lead 2, long lead 2 is what we say. So we go for 10 seconds, and in these 10 seconds in this ECG which is shared above, we can see that in 10 seconds there will be 25 smaller squares and 25 larger squares, and in this 10 seconds we see that there are 9 RR beats. So R beats multiplied by 6 will approximately give us the number of heartbeats, or technically speaking, number of ventricular contractions which are efficient. So although it is not the exact number which we look forward, because 27 small square will approximately tell us that there are 56 beats per minute. Large square also give us 56 beats per minute. But being the quickest method with R waves, in a flash, in 10 seconds, you will be able to assess what is the heart rate in this ECG. So in the above strip, 9 into number of R waves in 10 seconds will give you approximate how much heart is beating, and these findings are actually very relevant in acute care when a child is in your ER. You get a long lead to ECG and it shows 54 and you're not able to get any heart rate. On auscultation, you start PPR and you label it as pulseless electrical activity. And once you have given adrenaline, the same heart rate increases up to 102, and you decide to continue your resuscitation, and you do not give any more contraction. And with this as the modality to review this patient, the long lead 2 with the heart rate is the most important calculation which is needed. Once you have located what is the morphology of the rhythm, important consideration which you should always keep in mind is the paper speed. The usual paper speed set on the monitor is 25 millimeter per second. If you are going to double the paper speed, then actually the time in which the squares will also be changing. So with this increase in paper speed, the rhythm strip will now capture in 5 seconds. The total capture will be as compared to the standard 10 seconds. The size of the waveform will be visualized in a better way. So if you see the comparison between the two rhythm strips, one at 25 millimeter per second and other at 50 millimeter per second, you can see that in your monitor itself, you can actually try to check how much is the P wave different in morphology in upper rhythm as compared to the rhythm shown in the lower part of the figure, where you can see that the P wave which is shown is not having any subsequent transmission to ventricle, and this is sawtooth wave pattern seen in atrial flutter with 2:1 block. So thus, that after two P waves, the third wave is having a QRS complex. So once we have these kind of rhythms available, we check the proper waveform to understand what is the contraction and how much is the excitability of ventricle after the contraction has started in the atrium. Primarily in children who are having tachycardia or are having myocarditis, and if you're in ICU and you are searching for P wave to label whether this febrile child is going into SVT or is in sinus tachycardia. In initial stages, when you are not very much okay in analyzing ECG, this speed increment on your monitor is going to help you understand how is actually P wave morphology and how is this P wave morphology is associated with subsequent contraction. So when we see in this very example, if you see in the upper graph, upper part of the graph, the first P wave is not associated with any QRS complex, but the second is associated. So when we talk about 2:1 block, this is the morphology which we are talking about. On increasing the speed, the same graph is now better visualized, and we can consider it to be a good way of analyzing the rhythm if we are not that good in analyzing in beginning. What are the common ECG findings in children? Usually, a child will have a heart rate which will be more than 100. There is the particular right ventricular strain pattern in children, which is marked by T wave inversion in chest leads V1 to V3, right axis deviation, which technically converts into adult form axis as the child grows. Then there is dominant R wave in V1. Then there is RS R' pattern. There is marked sinus arrhythmias in children. There is shorter PR interval. We are going to talk about all these things in subsequent slides. Uh, Slightly prolonged QTC in infants less than 6 months, that is less than 490 milliseconds, and presence of Q waves in inferior and left precordial leads. So whenever we have to actually go and quickly check whether there is right ventricular strain and whether this is something which is significant, we check for V1 to V3 chest leads, and we have to see for ST depression and T wave inversions, because these V1 to V3 correspond to right side right ventricle technically, and inferior leads 2, 3, and AVF have also tells more about the right side. Going on to understand what we are talking, first example, let us see. In this is a 12 lead ECG with lead 1, 2, 3, AVR, AVL, AVS, V1 to V6. And this is a common ECG which all of us have seen in our practices. When we go, we see that this ECG, in this, we can see that V1 has a R, then a negative deflection of S, then again a positive deflection of R dash. And in this also you should note that in V1 this R, S and R dash pattern is there, but the first positive deflection is higher as compared to the second positive deflection. The next wave which is negatively deflected is P wave. This V1 RS R dash pattern is not seen in any other subsequent chest lead. Similar RS R dash pattern in V1 is also seen in lead 3. That means both the leads which tells about the right side of the heart have this pattern, and when we see what all actually this pattern are, then there is a heart rate which is 110 beats per minute, which we have calculated by dividing either 1500 by small square or 300 by large square. Then the T wave inversion in V1, V2, V3. This is known as juvenile T wave pattern, which is normal in a 2-year-old boy. If you see, when we say dominant R wave in V1, in V1 to V3, that means out of two waveforms, S and R. R has a higher voltage. So the length above the isoelectric line as compared to the negative deflection, that is the S wave, the R wave is more. Then if you see, like I mentioned, that RS R dash pattern is visible only in V1. Thus, it is a partial, look-wise, it is partial RBBB morphology, and it is not being carried ahead in other lead waveforms, V2 or V3. Going ahead with a normal ECG of 1 year, if you see, I have tried to highlight that the rhythm here, where we are calculating between by using the formula of the larger square or smaller square, the rate is 150 beats per minute. When we say there is right axis deviation, then we have already with part 2 mentioning about in detail how to calculate axis. Here I am just quickly going to tell that in lead 1 and in lead AVS, the positive deflect, the R wave is dominant and there is right axis deviation 0 to 90 degrees, and T wave inversion in V1 to V3, which we all now know is called as juvenile T wave pattern. There is dominant R wave in V1 as compared to the second positive deflection, and narrow QRS complex, which is very common finding in heart rate which is more than 150 in a child which is 1 year. So having a child with age of 1 year getting T wave inversions in V1, V2, V3 is normal finding. And if at all you calculate the heart rate and it is going above 120, then QRS shorter than less than 0.08 is also common finding. Going ahead with the ECG of 2-year-old child, we see that we have a similar finding as we have seen just now in age 1 year. But we can see that in lead 3 on the chest lead, V3, we see a positive T wave rather than a negative T wave. So upright T wave in the inverted T wave starts becoming upright in by age of 2 years. When we go to 5 years, now the rate has slowed down. Axis is normal. It is uh, in lead 1 and lead AVS we calculate, and it is normal axis, right axis deviation. And QRS width now seems to be approximately 0.08 second. And what is 0.08 second? That is the width of QRS should be not more than 3 small squares. So one small square is equivalent to 0.04 seconds. If you see that even in 5 years, the persistence of T wave inversion is seen. So T wave inversion seems to be as a normal finding in a child till 10 years of age. When the child reaches 10 years, this T wave inversion is gone. Just to summarize how these lead placement happens, because we have and we are going to use these V1, V2, V3, V4, V5, V6. So V1 and V2, they both go on either side as depicted in the picture on the fourth intercostal space. V3 stays midway between V2 and V4 in adults. That is, and V4 is kept at fifth intercostal left mid clavicular line. If we are keeping on the right side in certain specific circumstances like dextrocardia, we use the term V4R, and this should be labeled in the ECG. V5 is in the anterior axillary line in the same horizontal plane as V4, and V6 is in the mid axillary line. The limb lead should be kept at the top part of the arm or leg. Generally, all of us have seen that the sisters keep it at wrist or and at the ankle, and these define the limb leads along with precordial leads. Now we will go ahead and we will go step by step to learn how to read a pediatric ECG. The first step, before we go ahead with the first step, is to understand the rhythm. We have to understand that this rhythm in child starts with atrial depolarization at SA node. P wave will precede QRS complex, and PR interval will remain constant. Normal P wave axis, that is 0 to plus 90, P wave will always be upright in lead V1, in lead 1 and lead AVF. I'm not going to go in detail in this talk on how to check axis. In case those who are participant of the group, they know that in part 2, this part is already being covered and the video has been shared with them. In the non-sinus waveform, some atrial rhythms may have P waves in front of every QRS, but with an abnormal P axis, that is inverted in lead 2. So the prominent sinus arrhythmias, they are very common in children, and this first step to analyze the rhythm is very important. In a nutshell, P wave will precede QRS, PR interval remain constant, and the morphology with the normal P wave axis is between 0 to plus 90. And we have to check it for a positive deflection in lead 1 and lead AVF. If lead 1 or lead AVF has a negative deflection, then it is abnormal ECG. Step 2 is to define the rate. Rate in pediatric is age, dependent on age. For a normal newborn, heart rate is highest. As child age, heart rate decreases because younger the child, their metabolic rate is more and they have lower vagal tone. As the child matures, the autonomic nervous system matures and their heart rate becomes less and they improve in with that. When the heart rate becomes less, we have seen that how a QRS complex of a narrow QRS comes to the normal size QRS of 0.08 seconds. Step 3 is define the axis, and normal QRS axis also varies with age. It ranges from 110, and in adult is the range. When I say 110, that the range is from 30 to 180. So when you are defining about that this axis is normal or this axis is not normal, always remember that in young child, from newborn to infancy to adolescent, there is drift in what is normal for axis. So always remember that there is a chart for which you have to go back and check. A northwest axis, that is the axis between -90 to -180 degree, will always be abnormal. It is seen in AV canal or ostium primum atrial septal defect. So whenever we are checking for axis, we check in lead 1 and lead AVS, which is most important thing when we talk about axis. To revise what is this normal AVS and normal axis. So if you see in this image 0 degree to 180, there is a purple mark in first normal axis 0 to 90. Then when we see this is normal RA axis, then high RA, where we have a negative AVF and positive deflection in lead 1, that the axis is possible left axis deviation. When there is a negative in lead 1 and positive in AVF, then we have a right axis deviation of +90 to 180. And when both are negative, that is AVF is also negative, lead 1 is also negative. This is what I was saying, that is northwest axis, and it is usually seen in ostium primum atrial septal defect or in AV canal defects. Always remember that QRS axis in pediatric changes with age. Step 4 is checking the intervals. In this image, we can see that PR interval is start of P to start of QRS. QRS interval is start of Q to end of S. The J point deflection is where QRS turns and come to isoelectric point. T wave ST interval is from the end of QRS to the end of T. TP interval is end of T to the start of P. RR interval is between the two R wave deflections. QT interval is from the start of QRS complex to the end of T interval. This being the first presentation of this live webinar of ECG course, this whole talk is primarily about the normal aspects of ECG. We are going to cover abnormal aspects in subsequent slides and in subsequent webinars. So coming back to the step 4, we check for PR interval, we check for QRS duration. They are shorter at birth due to smaller cardiac size. There is a normal QT interval which is slightly prolonged at birth. So it is normal QT interval and it is slightly prolonged at birth. So when we talk about PR interval, there is prolonged PR interval which is noticed in first degree heart block. Again, we have age-wise PR interval, which is dependent primarily on the rate of the heart. 3 conditions where you should remember that PR interval abnormalities will be seen is myocarditis, hyperkalemia, and congenital heart disease. Digitalis toxicity is usually iatrogenic, I'll say, because a wrong dosage, once child has been seen by someone for congenital heart disease, treated with digitalis, leads to digitalis toxicity. So before the patient comes to your OP, if you see that in a small child is having a abnormal PR interval, then this type of problem, prolonged PR interval, should raise some doubt in your mind for myocarditis, hyperkalemia, and congenital heart disease evaluation. When we talk about QRS duration, again, there is QRS duration which is age-bound. Prolonged QRS duration is characteristic of ventricular conduction disturbances, congenital bundle branch blocks, WPW syndrome, intraventricular blocks, ventricular arrhythmias, all will have affection on QRS duration with morphology. We have lined up lectures to take care of all these problems. Today, just focus on 2 important points, that duration of QRS, duration of PR interval, everything is dependent on age of the child, and we have to have these normal durations at some point written or printed with us. QT interval, as we have seen, is calculated from the start of Q to the end of T. It varies with heart rate. Corrected QT interval we have to calculate by checking QT and dividing by the square root of RR interval. Usually in children less than 6 months, it should be less than 490 milliseconds, and above 6 months should be less than 440 milliseconds. The clinical conditions of hypocalcemia, myocarditis, Romanovard are head injuries, or in certain drugs, QTC is prolonged. QTC is short in hypercalcemia, congenital short QT syndrome, and these are calcium-based ECG disturbances, which are very important, and if not recognized, are very common cause of cardiac dysfunction in children. Step 5 in ECG evaluation is P wave amplitude and duration. Normal P wave amplitude should be less than 3 mm. For sake of an understanding, a square of 2.5, a length of 2.5 on x-axis and height of 2.5 in y-axis means that P wave is normal. We evaluate P wave, look at the P wave. If there is wide P wave, it is left atrial enlargement called as P mid-cell. If it is tall P wave, it is right atrial enlargement, and it is called as P pulmonale. A combination of tall and wide P wave can also occur in combined atrial hypertrophy. Step 6 is Q wave amplitude and duration. High QRS amplitude is found when ventricular mass is more, when ventricular hypertrophy is happening, or there is associated bundle branch block, or there is pre-excitation syndrome such as WPW. Amplitude will be less when there is extra fluid around the heart, or muscle is not functioning properly, or conduction is affected. It can also be there in normal newborns, but you should consider abnormalities first if you're getting low QRS amplitude. So pericarditis, myocarditis, hypothyroidism, or normal newborn can have low QRS amplitude ECG. When we talk about smaller children, right ventricular hypertrophy is something which comes to our mind every now and then. How do we actually analyze that right ventricular hypertrophy is there or not? So when we say right ventricular hypertrophy, tall R wave will be seen in right-sided lead V4R, also in V1. So dominant R wave. There will be deep S wave, negative deflection in left-sided leads such as V5 and V6. There will be abnormal right R by S ratio, and it favors right ventricular hypertrophy. Then there will be increased R by S ratio in V1, V2. And if R by S ratio is less than 1 in V6 after 1 month of age, it means right ventricular hypertrophy is there. When we talk about abnormal T waves in right ventricular hypertrophy, then there will be upright T waves in V1 and V4R in children 3 days to 6 years. This is evidence that there is significant right ventricular hypertrophy. That we should always remember that when we are looking at these abnormal T waves, the T waves are otherwise normal and upright in V6. Abnormal Q wave, that is negative deflection of Q with a positive deflection of R in V1, is highly specific of right ventricular hypertrophy. This, when we started discussion of a normal ECG, we have seen that in this ECG, there is right ventricular hypertrophy with R prominent, R dash smaller than R prominent, T wave inversion, and there is T wave, upright T wave in V6. There is no QR. So there is right ventricular hypertrophy, but this right ventricular hypertrophy is not which we want to actually discuss in detail, or this right ventricular hypertrophy is not abnormal as per age. So abnormal Q waves in V1, abnormal T waves in V1, abnormal RS ratio in V1 and V6 should highlight that right ventricular hypertrophy is present in this patient as per their age. Left ventricular hypertrophy is usually a problem of adults, and left axis deviation is usually seen with left ventricular hypertrophy, but marked left axis deviation is rare with LVH. Whenever we say left ventricular hypertrophy, we should start thinking about lead 5 and V6, where R wave will be more prominent. Deeper S waves will be seen in V1, as we remember just now that R wave is prominent in V1 otherwise. RS ratio will be abnormal, and it will favor left ventricular hypertrophy. Decreased RS ratio in V1 by V2 will also be seen. Q waves which were supportive of right ventricular hypertrophy in V1 now will be seen in V5, V6, and inverted T waves in lead V1 and AVL will show LV strain pattern. We are going to discuss with ECG in subsequent lectures. We are going to talk on this. One rule which I want you all to remember is the Evans rule. Evans rule says that an abnormal left ventricular large voltage LVH will be seen in V6. So if R wave in V6 intersects with the baseline of V5, it is abnormal. So any waveform where you see that the positive deflection in V6 is so positive that it is crossing the V5 waveform, seems left ventricular high voltage, left ventricular hypertrophy is there. When
upright T1,
RS pattern in V1, these are abnormal with pure R wave in V1. This is abnormal in child which is more than 6 months of old. In step 7, in ECG, understanding ECG, we have to remember the Q wave, which is the first negative deflection in QRS. Its average should be less than half of small square. Always should be less than the small square, which is 0.04 seconds. And it should be less than 5 millimeter deep in left precordial leads and AVF. It can be 8 millimeter deep in lead 3 in children younger than 3 years. Q waves are abnormal if they are present in right precordial lead, that is V1, which suggests RVH, like we have discussed. It is absent in left precordial lead in left bundle branch block. When there is abnormally deep ventricular hypertrophy pattern, we see Q waves in lead 1, AVL, V5, and V6, which is often seen in hypertrophic cardiomyopathy. In adults, when abnormally deep and wide Q wave is found, that is suggestive of myocardial infarction or old scar with fibrosis. ST segment, that is from the start of S to the end of T, we can see that at J point there is depression. J point is the point where QRS complex meets isoelectric line, and there are couple of normal findings where we see upsloping, downsloping, and horizontal as we see the slant as it cuts the isoelectric point. The J point deflection is depressed without sustained ST depression. This is called as upsloping of ST depression. When there is benign early repolarization, which is a common finding in adolescents, ST segment is elevated and is concave in lead with an upright T wave. So that pattern, which is suggestive of early repolarization, I have not shown in this image. Here we can see how upsloping, downsloping, or a horizontal ST segment depression is seen, which is abnormal. So we should remember that these ST segment changes pathologically are seen with T wave changes, and they occur in myocarditis, pericarditis, ventricular strain pattern, and digitalis effect. Step 9, that is T wave changes. The T wave configuration changes happens over time. For the first week of life, T wave can be upright throughout the precordial lead. From the first week, after first week, that is after 6 days, T wave become inverted. V1 to V3 we have already seen, that is called a juvenile T wave pattern. T wave inversion usually remains until up to age of 8, then it becomes upright. Thus, however, the juvenile T wave pattern can persist into adolescence and early adulthood, but it should be mentioned as persistent juvenile T wave. Understand this, that there will not be any cardiac compromise state, then only we say that this is persistent juvenile T wave changes and nothing else. Tall peak T waves are seen in hyperkalemia, left ventricular hypertrophy, or benign early repolarization. We are going to go ahead, and in subsequent webinars, we are going to talk about all these abnormal conditions. Flat T waves is seen in certain electrolyte imbalances like hypokalemia, in hypothyroidism, in normal newborns, in pericarditis, myocarditis, also in myocardial ischemia in adults. Last step in managing and understanding ECG is U waves. These U waves are extra positive deflection at the end of T wave, where they are the most common cause is hypokalemia. Normal finding is seen at a slower heart rate, that is sinus bradycardia, and sinus bradycardia is the presentation of hypokalemia as well. So when and this sinus bradycardia can have a U wave. This U wave should be understood and should not be confused with the morphology of U. It is not a negative deflection, it is a positive deflection. This positive deflection is between T wave and P wave. With this, I have tried to cover all the normal waveform in 10 easy steps, how you identify the wave, how you identify in a pattern where you start with rhythm, you decide how is the rate, you decide what is the axis, what is the P wave axis, how is the QRS axis, what is the PR interval, what is the QRS interval, what is the changes in morphology from V1 to V6, and what kind of hypertrophy child is having or not, what is the time duration that the waveform is going ahead, and how is the morphology of T wave, how is the morphology of other waveform and other patterns, and that gives us a fair understanding of what we have to keep a note of. At the same time, how we are going to analyze further, or at all if we do not have to further investigate this child. The normal ECG is very important, because if you know the normal ECG, then only the abnormal ECG will make any sense. If you do not know what is normal, then in child you can easily be trapped with the abnormal T wave inversion, which now we understand is a juvenile T wave pattern. And with this, I will conclude this talk. If at all there are any questions, then please put on the group. Although I think it being presentation with normal ECG, most of you are already aware. For those for whom the second webinar